Okay, so we're gonna do just endocrine today. I have this general kind of idea, general overview. And then it's just the rest of that is just focus on the three main conditions. Um, Focus again as always, mostly on all the stuff here that we'll fill out, less so on the patho, but the patho is there to help. So here, just kind of general outline, the pituitary gland. Just kind of looking at which type versus the other controls release of what. Not too important to memorize it at all. But what is important, I think, is just kind of having a general idea about ADH. So vasopressin, that's the synthetic form that can be given as a medication. So it's synthetic ADH, antidiuretic hormone. And the way it works is that the ADH is going to be released and cause your renal tubules to reabsorb more water. So by reabsorbing more water, it's able to maintain blood pressure. And it's also worth noting that ADH specifically retains water without having a direct impact on electrolytes. So you're not necessarily retaining more sodium. So if you have a lot of ADH, you're retaining only water. So you're increasing your water that you have with you without increasing the amount of sodium you're retaining. So that's why, as we'll talk further, your SIADH includes hyponatremia as one of the complications. Here, it's released when the serum osmolarity is high. Within normal limits is 270 to 300. Um, it's released also when the blood pressure is low or the blood volume is low. So here, when there's too many electrolytes, not enough fluids. When there's blood pressure is low, blood volume is low. Yeah, just a general overview. So when it comes to your conditions, you have the syndrome of inappropriate antidiuretic hormone, SIADH, and the easiest way to remember this is going to be with SI for soaked inside, meaning that it's related to fluid volume overload. So again, we said this is too much release of ADH. So if your ADH's entire purpose is to retain water, that's exactly what your body's doing. It's retaining a whole bunch of water. If you're retaining water, that's where your FBO is going to come from. It is a slow progression, but the key concept here is going to be this right here. It's going to be a concept. Some of the causes that could lead to SIADH, we did talk about small cell carcinoma, um, how SIADH is a potential complication of that when we did, but now we're actually going to talk about that condition, some other disorders that might cause it. But again, the focus is not so much about this as much it is about your manifestations and your labs. So we already kind of talked about hyponatremia, so I'll kind of just keep that there. Delusional hyponatremia. And do we all understand why you have delusional hyponatremia? Or do you want me to explain it again in a different manner?
Because your fluid volume overloaded. So
Yeah, exactly.
fluid, less stuff in the blood.
Yeah, so like Michelle mentioned, the ADH causes too much retention of water in just water. So if you imagine your cup full of salt, you um, add more and more water, that salt level concentration decreases, even though the amount of salt didn't change. But even though the actual physical amount of salt didn't change, it gets diluted more and more and more. So that water is going to taste less and less salty every time. So that's the same concept there. So this condition, you're going to have the. Oh, sorry, I didn't actually. I realized I didn't have chat up. Okay, so let me see what I got. Water diluted, yes. Yeah, similar to CKD, you're going to have that delusional hyponatremia as well. Okay. Anything else that you'll see in terms of labs? And here, Yeah, so low sodium, low osmolarity, osmolality. They're pretty similar, honestly, the difference between the two. High concentration. Yeah, so some of the things that you'll see would be, yeah, the high concentration of urine. So even though, so you're not peeing much, so your body retains all this fluid, so you're not going to be peeing very much. But the urine that does get peed out is very concentrated. So you will see an increased urine specific gravity. So we'll say about higher than 1.03, so a high urine specific gravity because you're so um little urine, but the urine that gets made is very concentrated. Yep. So that something else you might see maybe like your osmolarity would be low, so low osmolarity, low blood osmolarity, because again, when that number is low on your with your normal being 270 to 300, um that means that you the concentration of electrolytes is low, and in which case here it's because it's being diluted. Yeah, don't worry about the difference. It's not going to come up on the test in terms of like difference between the two. From what I looked up, um, one of them I think is in units of kilograms. The other is in units of um, I think liters. And I think one of them's usage is more like affected by temperature than the other. But again, don't really worry about it. Don't worry about it. It's not going to come up. So just kind of go off the number that they've been going off um since forever. Yeah, they go about it a bit more in chemistry, but I don't honestly remember. I do remember they are technically different, but it's not really a big there's not a big need to know the difference. So in terms of assessment, so we said high urine osmolarity but low serum osmolarity. Yes. So in your blood, you're retaining everything. So concentration is down in your blood, but in your urine, you're just trying to get rid of stuff. You're trying to get rid of as much waste without using up fluids because your fluids are trying to be retained by the antidiuretic hormone. Yes, so osmolality is actually, yeah. So I believe osmolarity is one of them again, the units are slightly different. So one of them uses kilograms, one of them uses liters, and technically the kilogram is roughly equal to the liters, and whatnot. But yeah, you don't have to worry about it really. So we already talked about oliguria. So we talked about you're not going to have much urine. So that's oliguria. So the patient's going to be oliguric. Not going to be able to pee much because their body's retaining all that fluid. So ADH. So we're going to have oliguria, but very concentrated urine. Anything else what else is definitive or what else is like characteristic of FPL? Yes. So possible crackles, lungs, so pulmonary edema. That's always going to be one of your key things that you're looking out for. Perfect. So increased blood pressure, pounding pulses is also going to be like a really good indicator of fluid volume overload. So your compensatory factors, yeah, when you have FPO, you have compensatory factors. So tachycardia, and you can also assume tachypnea as well. So those are your two big signs of um how you say your big signs of your changes here. The cardinal sign, yeah. So your hyponatremia is going to be one of your big ones. So we can talk about some signs and symptoms of hyponatremia. So what do you guys know about it? Are other electrolytes diluted? So the main thing to note is that for most of the electrolytes, most of them are actually found inside of the cell. So in terms of like bioavailability for your body, the fluids don't impact the other electrolytes quite as much as it does salt, where salt is almost uh is like mostly in the blood as opposed to inside the cell. So that's why in 212 we learned about delusional versus depletional hyponatremia, but there's no um real differentiation between any of the other electrolytes as compared to that because salt is more affected by delusion than the other ones due to the nature of it being outside of the cell. So here, Ryan mentioned the seizures, lethargy. Yeah, so that's going to be a big key thing is that seizures when very low. So I would say maybe like about under 125, you can start seeing risk of seizures, lethargy. So we're going to have a lot of these um, symptoms that kind of similar to very similar to kind of like a neuro deficit. Um, at- yeah, and nausea, vomiting that could happen as well. Something else in terms of outside of like neuro, what else can we think about physical assessment wise that you can kind of associate with a lot of these electrolyte alterations? Yeah, so muscle weakness, muscle cramping. So we're gonna go with muscle cramping, muscle twitching, weakness. And as always, it's worth keeping in mind anytime you do have muscle weakness, muscle cramping, due to electrolyte imbalances, it's worth always thinking about how that can affect your breathing because your can you clarify the BP is a good indicator of this because hypertension is due with FPO, however, hypotension is seen with low Na plus. Can you clarify a bit more about what you're asking here? Is blood pressure a good indicator of this?
So I was just reviewing the signs and symptoms of hyponatremia,
Yeah.
and hypotension is one of them. And then it's kind of contradictory to the fluid volume overload signs and symptoms, which hypertension is included in those.
Oh, okay, I
So
see.
I wasn't sure. Is it just does it just mean that the BP is going to be all over the place? It's not going to be stable, or
So
what?
in that scenario, that's kind of referring to the different types of hyponatremia. So you have delusional versus depletional, but you also have hypovolemic and hypervolemic hyponatremia. So you can have a hyponatremia that's due to the body wasting salt and water, or you have a hyponatremia due to fluid volume overload diluting it. So you can have different ways of having hyponatremia. So another way to have hyponatremia would be someone who is getting Lasix or some sort of other diuretic, and they're being diuresed so much that their electrolytes are low. So that in that sense, you can have your hyponatremia with hypotension and with other things like that versus in this scenario where someone has FBO and that's causing the hyponatremia. So like I mentioned before, the hyponatremia, the salt electrolyte in particular is far more impacted by your fluid status. So you do have different ways of getting to the same hyponatremia versus hypernatremia, as opposed to the other ones. Yeah. And then Josh mentions hypo and tachy for tachy, which one? Heart hypotension or like which one? What are you referring to? Um, in terms of for this specific condition, it doesn't really correlate as much. And in this case, the tachycardia because of the FBO in general. I guess we're just looking for hyponatremia specific stuff here. But they already mentioned kind of consider the the diaphragm is of muscle. So when you have these muscle weakness, muscle twitching, muscle cramping, consider that the diaphragm is a muscle and is impacted. That could affect your breathing as well. But yeah, the tachy we mentioned here. And again, we talked about how in this scenario, your hyponatremia is due to fluid retention, therefore you have hypertension rather than hypotension. But you can have hyponatremia occur with hypotension, but that's in a different context. Yeah, so you're gonna have hypertension because you have FBO. So um to kind of break it down a little bit better. So we have hypovolemic hyponatremia And this is review from previous. This doesn't specifically have anything to do with hypervolemic hyponatremia. So like we mentioned, hypovolemic hyponatremia is hyponatremia due to low fluid, in which case causes of this could be diuresis. You're losing so much salt and water together. So you have hyponatremia, but it's accompanied with hypotension because you're lacking in fluid volume. You're being overly diuresed. While here, hypervolemic hyponatremia is dilutional due to FBO, where your total, so here you have real salt depletion. So we have real salt depletion. So here you have a low actual number of salt, while here it's purely delusional because remember your lab values that you have when you take blood labs are not um are not measurements of the amount of electrolytes per like in terms of like a mass or like the quantity, it's a concentration. So that concentration um is affected in some way by the fluid, but because your salt is primarily in the intravascular, so in the blood outside of the cell, it's even more impacted by the change in fluids than your potassium and whatnot. Does this make sense? So in this case, you have to separate the two. So in this case, we aren't thinking of this one right here that I'm highlighting because that's not the situation that's happening with this condition. This condition is purely fluid volume overload, and the salt is low because of dilution. But again, the body works off concentration and not just the exact number. So for the body, again, going back to that analogy where you have a cup and you fill it up with, let's say, two tablespoons of salt, and then you add a certain amount of water. You add more water, it tastes less salty. Um, it might have like a lot of salt in it, but because it's diluted, it still doesn't taste very salty. And your body works more off the end result than it does just the pure number, if that makes sense. So like if you're tasting food, you're complaining about it not tasting salty, not because there's not like a certain amount of grams of salt, but because it's so diluted you don't taste it. If that makes sense. Like how you can have like your Dunkin' Donuts coffee and be like, this tastes sweet, but not too sweet. But then you look at the nutrition factors and it's like got 100 grams of sugar, but it's because it's diluted by a whole other stuff, whatever they add. I don't know if that made sense, but the idea is that the body is looking at the concentration, not just the raw numbers. Yeah, let me know if that made sense. I kind of just went on a tangent. Okay. So we said nausea, vomiting, blah, blah, blah. Said that. Mentioned the edema. We'll just kind of go here. Possible carpal pulmonary edema, peripheral edema. Again, we're FBO. A lot of these are FBO based. If you're if you are FBO, you're also having increased weight. So that's where again, like Miss Brooks mentioned in the kidney labs and in the kidney lecture, your daily weights are important for seeing changes in F and E. Yeah, the best indicator, which is unfortunate because they don't really. I don't, have you guys ever seen them actually take weights daily at the hospital? I just think it's funny that's like but I guess just because it's a pain in the ass to do. Oh, nice. Yeah, they have the bed weight. It's just that it's kind of a pain to get accurate because there's so many factors. So like the idea would be like you're taking everything off the bed. So people don't want to do that, so they just don't do it. Yeah, they usually will use the bed weight though. And that should be pretty much that in terms of your possible assessment. Yeah. Now, in terms of management, a lot of this is gonna um deal with your fluid and electrolytes. So let's kind of break it down into managing symptoms versus managing some of the more dangerous um things. So let's say how is the management for placing lost sodium or how about treatment of hyponatremia? How would you mind? Yes, exactly. So can be treated 3% normal saline. And it's yeah, this is a high alert medication. So the reasoning why is because this is a hypertonic solution. So this is a hypertonic solution. So, initially when you're giving it, it's going to even out the concentrations, right? But over time, it's going to start building up that concentration of electrolytes in your blood and cause fluid shifts. Yes, exactly. You could reverse it from going too much. So when it comes to your hyper and your hypo, you can you can cause the opposite problem because it's going too much. So not even just the hypernatremia, but also just the fluid shifts. If you go too hard on the fluid shifts, with your hypertonic solutions. Remember, water likes to follow solutes. So if you have too much concentration in the blood, you'll have the fluids in the cells rush into the intravascular rather, and then your cells would be lacking in fluids, which can cause some of the other symptoms of hypernatremia, like the altered level of consciousness and whatnot. And then likewise with the hypotonics, over time it built up a higher concentration of electrolytes in the cells. So the water would likely go in the cells, and then too much of that, and then the cells burst. And then that also can be a reason for why you can have altered level of consciousness. So the point is, you have to be very careful because it can lead one way or the other to different types of issues with like neuro and stuff and different fluid shifts. That's where a lot of your ultra level of consciousness comes from. So in this case, you do have to be very careful with this. This is a high alert thing. Yeah, so must be careful, high alert, opposite issue. You can um go for hyperemia. Additionally, it might actually cause worsened um FBO. So, because you are giving an infusion of fluids when someone that's FBO would normally rather not have fluids, right? They would rather be on a fluid restriction. Is it 3% NS or NaCl? That's the same thing. So, NS is NaCl, but NS is typically referring to 0.9%, and 3% is just a higher percentage in the fluid. Okay. So kind of like I mentioned before, you're gonna manage um that treatment of your FBO. How do we treat it? So there's fluid restrictions. Think fluid restrictions will be your number one because the thing to be careful of with the diuretics. So diuretics can be something, but you do have to be careful with diuretics because that's again going to promote the removal of salt. So the way the diuretics work are that it causes salt to be released, and then that causes water to follow. So it will help with the FPO, but it could cause the sodium to drop also. So Michelle mentioned the vasopressin receptor antagonist. So then they're called I forgot, they have like a T in the ending, but they're aquaretics. So they would be medications that only impact the ADH, yeah, the vaptins. That's what they are. essentially are like diuretics that only cause release of water without the electrolyte because they would be interrupting the receptors for the vasopressins. The thiazides are a different class, and those are just like your usual diuretics. They will still cause depletion of salt and potassium, but the vaptins, those will work against ADH, so they're ADH antagonists, and they will only cause the release of water by itself. But they're also worth noting that I believe in real life it is more common to actually just do like a very low dose of Lasix or thiazide diuretics, simply because the ADH antagonists are harder to manage or like harder to kind of not titrate, but like it's harder to you can go like too much in the opposite direction easily as well. So the same way with the 3%. Yeah, in general, you want to be really careful because again, with the diuretics, if it's Lasix or thiazide, you can drop their sodium even more. If it's the vaptin, so the aquaretics, the vasopressin antagonist, um, yeah, then those could cause the opposite problem, just like the hypertonic saline as well. You have that black box warning actually on the vaptin. So if you open up your drug book, the vaptin drug, so the medications that do that, the aquaretics have the black box warning for you have to monitor for overly high increase in sodium as well as possible demyelation of neurons. So that's a black box warning on them. Why the first line should be fluid restrictions, but that is something that is included as well. So you can have diuretics and aquaretics. So it's gonna, but every time you think about, I think she in my class, I think she said less than 800 ml a day. But I've seen different numbers. It's up to the policy, up to the doctor. But your fluid restrictions is eight first line 800 ml per day. And it kind of has like the is it basically what the output is? I would imagine that that's something that could make sense. So kind of like the kind of like the in the kidney chapter, you could take whatever the output is and add, I think, 200 ml, and then that would be your next acceptable intake because you're taking into account the insensible losses from um just losing weight naturally. PowerPoint says 500 to 1,000. Okay, sure. So go with whatever it goes with, but the general idea will be in this around the same ballpark here. And the concept is you're doing this restriction if your sodium is above 125. And if it is over 125, then you're breaking that fluid restriction by giving the 3% hypertonic. Sodium is under 125, then you're going to do the 3%. And as to try to rescue them from from the critical low sodium, if that makes sense. And this kind of follows the idea of least invasive first, because it's less invasive to restrict fluids than it is to give a bunch of medications. So then we talked about the diuretics. So this would be a low dose of Lasix or thiazide. And I think someone mentioned Bumex. So worth keeping in mind that the Bumex is actually stronger than the Lasix, like 40 times stronger than Lasix. I think Lasix is the strongest, and then the thiazide is, I think, one of the weaker ones. And then the Bumex is stronger than the Lasix. So, yeah, but the idea would be low dose of that in order to diurese, but also be careful. Careful due to um the loss of electro and the meds. So if hyponatremia is already a problem, then you got to be careful with these. And the reason, again, it's not first line is because, yeah, exactly. And then aquaretic. So here I'll give examples. Well, examples here are the vaptins. Vaptin. Example is tolvaptan, onivaptan. Yeah. It's worth noting these are ADH antagonists. They will lead to water loss without direct electrolyte impact. So unlike the diuretics, you're not losing the sodium and potassium, but it is still going to cause fluid shifts because, like we mentioned, the ADH. So when will we know to give the diuretics? Whenever in real life, it will be whenever the doctor tells you that he thinks we should do it. Because again, you don't make the decision whether to do it or not. I guess you get to choose to hold it, but in that case, um, it would be kind of up to how the patient is doing. So if the patient is not improving in when you're doing the fluid restrictions, they might have to do more aggressive treatment. They tell it to stop holding on. Oh yeah, the black box warning. So the black box warning is really for rapidly increasing sodium. So again, going the other way, similar to the hypertonic sodium, and can cause demyelinization. So why does this happen? Because kind of like we talked about, the rapid fluid shifts cause fluid to escape the cells. The cells can then lyse from the lack of fluid, and then imagine that happening in your brain. So imagine kind of like rapid shifts, cells, brain cells burst, or brain cells lyse. Okay. Do we kind of get the idea between like the fluid restrictions versus diuretics? The aquaretics. If I recall, the focus is more on understanding these two more than the aquaretics. The aquaretics is just kind of like a for fun thing that's on the PowerPoint, but it's still worth noting, I think. All right. So other than that, you can of course do um identify and remove the the underlying cause. So in this case, again, very common for it to come from lung cancer. So lung tumor removal, because one of the potential complications from small cell carcinoma is SIADH. A safe environment, because if someone, one of the big things with this condition is the hyponatremia. So making sure that they have seizure precautions going, nursing station, cluster your care, minimize the stimulation. So just kind of ongoing assessments. So for example, keep assessing the level of consciousness, um, lung sounds, like assessment of lung sounds, because echoes pulmonary edema, vital signs, so especially focusing on like the BP, heart rate, and if they're having pulmonary edema, then also maybe like their lung sound, all that stuff. Having breathing and stuff as well. Assessing their urine output, because we can use that as well to kind of see what their appropriate intake is going to be. But in general, I guess I'll do this. So 500 to 1000 ml or less than 800. So whatever it is that she said, she might have said both of them actually at the same time. Like the PowerPoint might have said this and the other one, but it's not a big deal. It's not going to be like, yeah, I think she said both, but it's not going to be like she says. It's going to be like a number that makes sense, right, on the test. It's not going to be something that like confuses you. Not that bad. Okay. Any questions on the management or anything like that? The only other thing maybe we could talk about would be seizure precautions. Again, review of seizure precautions, um, stuff. So it would be like O2, suction, added side rails. I like having making sure they have 2+, large bore, IVs, as always. You need the large bore IVs for rapid infusion of benzos in case they go into status epilepticus. And if someone's in that situation, you're going to want at least 2 IVs because imagine trying to put an IV into someone that's having tonic-clonic seizures. It can already be hard to just put an IV normally. So, reduce stimulation. That's not really a precaution, but it's just kind of a good thing. Yeah, so that goes here. Your patient close to the nursing station, so you can do that. Yeah, that's pretty much how that goes there. Worries. Any questions on SI-ADH? So kind of going back up here and rereading, I think just make sure you understand how ADH works. So how this is a retention of water. It leads to specifically just reabsorption of water. So it's not going to directly cause a retention of sodium, or it's not going to directly affect sodium. It's going to indirectly cause dilution. SI-ADH, SI for soaked inside, FBO. So make sure you definitely know the assessments. So what goes with FBO, what goes with the hyponatremia. Remembering that the diaphragm itself is a muscle. So if you're having muscle weakness, cramping, it might impact your breathing. Definitely understand the management difference between um, the difference between the fluid restrictions, why it makes sense. You're going to have fluid restrictions up and as long as their sodium is not in critical range. If their sodium is in critical range, then you're saying we don't care about the fluid restrictions at the moment. We're gonna make sure that their sodium is not in critical range. Um, kind of the understanding. Desmopressin is the synthetic form. So desmopressin, yeah. So vasopressin is the vasopressin and desmopressin are the same med. I believe one's the generic and one's the brand name. I think desmopressin is the brand name. But, or am I trolling you? Or is he, yeah, either the same med or the same match. Yeah, they're both a synthetic analog of vasopressin. Yeah, yeah, it's just that yeah, it's for DI because DI the issue is that you don't have enough ADH. The real hormone, yeah, if you get what I'm saying. Desmopressin is vasopressin, which is your ADH. Yeah. What are you guys confusing? Oh, you're saying vasopressin is the real maybe? Let's actually see. Let's find out. Oh, I guess so. Okay. So vasopressin is just another name for. Okay, fair enough. Do it like this. This, and this is the synthetic. Yeah, fair enough, fair enough. What is that? Is that candy?
it ins- instead of open you normally do pedal, you go the opposite.
Wow, that's weird. But what is it?
It's good. It's a smelly good.
Oh,
I need you to open it,
oh, you
please.
need me to open it.
Get it. That way of how you would open bottles.
This
Oh,
way.
you got one.
You mean stop? It's the same way.
What?
There you go. It's the same way. It's lefty loosey.
I've been tightening them this entire time.
You've been tightening that the entire time. Yeah.
Oh no.
Okay. Anyways. Okay. Any questions about SIADH? Otherwise, we can move on to diabetes insipidus. So, DI, this one's going to be the opposite issue. You're going to have not enough ADH, or your kidneys are just not responding properly to ADH. So either way, and same end result. So the ADH's purpose is to retain fluids, so retain water. So if you're either not making enough of it or your kidneys don't recognize it, then you're not retaining water and you're just peeing it all out. Even this one's that's why it's called diabetes. It's referencing diabetes because both of them have that polyuria going on, even though this one's not really related um to sugar levels or insulin. This one's related only to the ADH. Yeah, so you're gonna have the opposite problem. So the key thing here is just remembering DI for dry inside because you have excessive urination and you're gonna have fluid volume deficit. So that's the key for this one. But here I have a list of causes, but again, it's really not the priority for you to know so much the causes, I don't think. But head trauma, brain tumors. Yeah, I also have here hypopostectomy, so that's after a removal of your hypothalamus. I think the general pathophysiology for this is your the hypothalamus and the pituitary gland kind of work together for the release of the ADH. Did we talk about it somewhere here? I think we kind of just mentioned that the pituitary gland is going to be releasing ADH. The hypothalamus is something that kind of signals the pituitary gland to do so. So if either of them aren't working, then you're going to have issues with your body making ADH. And there are different types here. Again, just kind of get a general idea. Just know that how do you have issues with the ADH? Having a natural congenital, so from birth defect, um, on the two main things that are causing it. Otherwise, from having like a tumor in that area, so it's like affecting the the ability of your hypothalamus or pituitary gland to make the ADH. And then the other one is nephrogenic, like we talked about, is if the kidneys aren't reacting well to the ADH. So I think don't the specific types aren't as important, but what is important is just the general idea of is it affecting the pituitary gland or hypothalamus, or is it something that's causing something with the kidneys? Because there is something, the water deprivation test, that's higher purpose is to kind of tell them apart because the treatment will be different depending on which one it is. And I'll explain later. But nephrogenic versus neurogenic is going to be your main thing. So again, is it affecting or is what it was the DI happening because of something with the hypothalamus or pituitary gland, or is it happening because of the kidneys? And again, they have different treatments. And then here's just kind of a general thing that could cause to lead to nephrogenic DI. So polycystic kidney disease, medications. Again, don't worry about it. It's just kind of there for your own information. Okay. So what can you guys tell me about the water deprivation test? Am I gonna do a final review? Maybe with Kaylin or something? Yeah, so it's kind of in the name, like Ryan mentions, you're gonna be deprivated from water. Yes. So what is the purpose of giving the desmopressin? So what happens if yeah, because like the desmopressin is synthetic ADH. So essentially, yeah, it but there's one reason this is an assessment. Exactly, yes. So that's the main thing about this is that the purpose is that they're checking to see if if this condition is neurogenic versus nephrogenic, because again, they have different treatment. So if the desmopressin has an effect, that means that the issue is that the body just doesn't have enough ADH. So how did that help? How did the desmopressin help? Is because it is ADH, synthetic ADH. So the ADH helped to make up for the lack of it. But if it's not doing anything, then it's a sign that it's the kidneys. So by if we pump you with ADH and it's not doing anything, it's not because you're lacking ADH, it's because your body doesn't know what to do with it. It doesn't react, kidneys don't react accordingly to it. So if the desmopressin um neurogenic, does that make sense for everyone? So that's the key thing with this one is that it lets you tell if something if it's a neurogenic or a nephrogenic PI. 'Cause this is ADH, so neurogenic. We all understand this part right here? Cool. Now, what are some labs and manifestations? What are some signs and symptoms? I can go right ahead and type this one because we've been talking about it for so damn long. It's the polyuria, and we can kind of put polypeptia there too. If you're constantly peeing, you're also gonna be constantly thirsty. And there are some parameters that I'll include, but otherwise, you guys can just kind of start listing stuff that you guys can remember. We'll talk about it. So on average, the urine output, this person's going to be peeing a hell of a lot, 5 to 10. Don't bother about memorizing the exact number, but just kind of get an idea that that's a lot. Yeah, they're going to have diluted urine, so they're peeing so much that urine's gonna, yeah, pretty close. Yeah, that's actually pretty close. To be peeing a lot. Yeah, they're gonna have low specific gravity, so diluted urine is low specific gravity. And this is gonna be large quantity, low quality. Put it there. So what else can we see? What's the main issue going on here? What is all this peeing gonna do? Yeah, so you're gonna have fluid volume deficit. So fluid volume, and you're also gonna have an indirect effect on the electrolyte. So you're not gonna be, 'cause remember that your ADH is affecting your retention of water and just water. So even though you're not actually peeing out your electrolytes, well, I mean, you are gonna be a little bit, but you're not. The majority of that is gonna be just water. So you're gonna have the opposite problem as that we had from ADH. We're actually gonna have an increased serum sodium. So that's gonna be the big thing there because now we have a loss of a lot of water without the loss of sodium. So we're gonna have hypernatremia here. And to explain why that works is lack of EDH affects reabsorption. So essentially, your urine has the same amount of sodium being treated that a normal person would, but now it's getting rid of even more water. So you're going to be hypernatremic. Yeah. And when we talk about fluid volume deficit, so what are some signs and symptoms that you can see that are associated with fluid volume deficit? So some physical symptoms that you might see in this person related specifically to FED. Some vital signs. Yeah, so poor skin turgor. And to go with that, we can say dry mucous membranes. Yeah, so compensatory factors, and we said hypotension, perfect, tachycardia, as well as tachypnea. So you see that FBO and your compensation is always going to be the same kind of way. It's going to be going tachycardia, tachypnea. Yeah, they're not going to be affected directly. So for both of these conditions, your main thing you're worried about is your sodium level. So with the SIADH, it's going to be low dilution. Here it's going to be high because um, you're getting rid of a bunch of water without getting rid of it's the same amount of salt. So the salt keeps building up. So even though you didn't actually change the amount of salt that's in your cup, you got rid of water. So that cup is now that drink you're having is now extra salt, even though the number of sodium is the same. Um, Something else I would like to include for the fluid volume deficit is just alter level of consciousness as we're dehydrated. That's like a late sign though. But that's like a late sign of dehydration. Some other things maybe like a flattened hand veins or flattened veins, sunken eyes. Yes. All right. What about your hypernatremia? And that's one I'll just kind of really focus a lot on the muscle, again, muscle weakness, muscle cramping, muscle twitching. It ends up being most of the same stuff, but your main thing is really focusing on is probably a little bit more scary than the seizures. I believe seizures don't occur with hypernatremia as they do with the hyponatremia, or at least it's not as big of a concern. I'm sure it can still happen, but it's more associated with the hyponatremia. I'm not even sure what level of hyper we'd have to look it up actually. Looks like it is more associated with, or it's associated with a sodium level of above 160, but they don't really emphasize it as much for this one. So, uh, I would say the biggest concern is your hypovolemic shock. Yes, low volume deficit's your bigger one, but definitely still worry about the hypernatremia. Again, it's not like a potassium where your hypernatremia has a bigger range where it can be abnormal. For this one, the I guess you can say the quote unquote nice thing about it is that they're um Well, I guess I wouldn't call it the nice thing about it, but it's like they're losing a lot of fluid, so that's like your main concern. That's part of your ABC, so you're focusing on that more than anything. I think most of your test questions will be focused on fluid volume deficit, but just always keep in mind about your hypernatremia. It is a thing. It can cause the muscle cramping, twitching, and weakness, and that can lead to breathing issues sometimes because the diaphragm's a muscle. And as I looked up just now, it can also cause seizures when it's really, really high at like 160 plus. But here, that's not really as emphasized on the seizures part, likely because the way the treatment kind of works, because we're so worried about restoring FNE, that just becomes your main thing, and we kind of have a direct, we kind of have a, if they're neurogenic, we have a direct way of helping them with just ADH and making sure their fluid levels are good. If it's nephrogenic, then we kind of have to, it's definitely a lot harder that way. Yeah, the kidneys are not doing too good. Caitlin says the kidneys are rebels and they don't want to listen. I know what it is.
ADH is there. And
Yeah.
she's like, not about that life. So that's why
Well, if they're not about that life, they're not going to be live. Okay.
well, they're not about that life. ADH.
Mm.
And so they put in more bosses and she's like, no, girl, I ain't doing this. Get me out.
Josh says, are you sick? Yes.
When am I not sick?
Yeah, she's been sick like
I'm
all.
sick and tired of sick.
She's been sick like all month.
Gaga.
Ah. He says hugs.
Thank you.
Virtual hugs from him. And
Virtual hugs.
I'm sure from everyone
I
here.
was like, but not too close. I don't want to get anyone else
But
sick.
you can give them virtual sick. Actually says, hope you feel better.
Thank you. I feel like we all had this conversation a really short time ago too.
Probably, huh?
It just happened. Yeah. I swear to you.
So with your management, that focuses a lot on fluid treatment of hypovolemia and shock, whatever is gonna happen there. So you're gonna do assessments on their vital signs. You're gonna do strict eyes and nose to measure, like figure out what's going on with that. IV fluids and stuff. Increase the blood volume, maintain the blood pressure. So the fluids. That's for what's the best IV fluid? Because again, you do want to still kind of want to care about the hyper. I'll actually see. The fun things about IB fluids is that even like a lot of the MDs disagree with what fluids to give in general. I looked at a Reddit thread when I was going over this for like second semester,
Source.
and yeah, it was like a Reddit thread between the doctors being like, all right, guys, what's your favorite fluid? Like, how do you give fluids in the hospital? And there were a bunch of doctors in the comments giving completely different answers, fighting over what the best fluids are. So it's like, oh man. So I'll look it up actually.
Where they live. It's okay. Wait, are you looking at the thread again?
Yeah, I guess this makes sense. Yeah. Like half an S, so you're not giving them you're still hydrating them without giving them much salt. So again, something that I guess is overly simplified when it comes to fluid shifts here, because it is actually extremely complex. Is that you think about like we're kind of like taught to think about hypotonic fluids go into the cells, hypertonic fluids go intravascular. But when the person's fluid electrolytes are off, that shift doesn't happen immediately because like for someone like in this situation, if someone has a lot of has a little amount of fluid in them and a lot of salt, giving them like a hypotonic solution is actually going to even them out and not cause giant fluid shifts immediately because it's still kind of evening it out because you're giving a lot of water with a little bit of salt. It's not causing huge fluid shifts because you're actually just kind of bringing them back to normal lines. But it's over that long period of time where it starts to shift the other way, and then that's when you have the fluid shifts that are detrimental. If that is making sense. So when someone has here hyponatremic because of how little fluid they have, then something like a half an S is more likely to is not as really as likely to cause the fluid shifts initially, at least. But it's still something you have to monitor. Um, because when you're giving the isotonic solutions, you're thinking about you're giving them too much salt when they're already hypernatremic.
Give them more
And
salt.
again, the hypotonic solutions wouldn't instantly cause the shifts into the cell because you're evening them out. It's just that you do have to monitor for it. But again, it's very complex because there's a bunch of other factors. Like in the SI88 example, the hyper natremic solution is going to help with the salt, but it's also giving them extra water. So you got to start thinking about. Yeah, it's just a lot of really complicated stuff going on. It's really not as simple as we try to simplify it as. But thankfully, you're technically not the one that's doing it, so that's not having to think about it. So you'll instead have the nephrologist and the cardiologist and the pulmonologist all duke it out. Yeah, I had actually in my preceptorship, I had the nephrologist and the pulmonologist kind of duke it out over the patient's IV fluids, and the nephrologist got really mad. I think I might have told the story before. The nephrologist was like had a like hour-long rant telling my nurse to call the pulmonologist and tell the pulmonologist to stay in their lane. I was like, oh man, that's crazy. Sorry. So for IV fluids, I believe it's gonna be a bit more appropriate for hypotonic, but again, extra information that is not tested. They just kind of say IV fluids, so don't worry about it. But yeah, in general, isotonic solutions, you're monitoring for, fluid volume overload, pulmonary edema, and with the hypertonic and hypotonic, you're assessing for those as well, and you have to assess for all the other stuff that can occur because of it. So electrolyte imbalances more likely to happen. Um, big, fast, rapid shifts more likely to happen. Again, it is very complex fluids. Even isotonic solutions. So, like I said, in that Reddit thread, doctors were saying, don't give any maintenance fluids. You're going to give my patient um, hypercaloremic metabolic acidosis. I'm like, oh, uh, like whatever. It's just, yeah. So in that Reddit thread, I saw doctors saying, I give very specifically, he gives B5 Havaness with a little bit of vitamins. And this other guy's like, I don't give any IV fluids. My entire job is to make sure nobody's on, or like nobody that needs it, nobody that doesn't need it. I just do two double negatives. Just to be like, you're on IV maintenance fluids, you don't actually need that. Get rid of that. So it's just like, again, just very complicated. But all of this just to say, just know that you want to give them IV fluids, but the emphasis is not on you to know which type. But here's just extra information. Sorry, I just wasted a lot of time on that rant.
But you had fun.
Yeah, I did have fun. So assess urine output, strict I's and O's. In general, that's going to be your big thing with manage blood pressure, vital signs in general. So your heart rate, how is it? Is it compensating still? Is the respiration rate compensating still? Did you go overboard? And then you can have treatment of the um, neurogenic desmopressin. So during that water deprivation test, that desmopressin was doing the job, so we're gonna keep doing the desmopressin if it's neurogenic. And then just in case it's given IV piggyback, could be given nasal, it could be given sublingual. What happened? Did you cut yourself? How? It's nephrogenic. You know that the ADH will not help.
Don't listen.
Mm,
I'm sorry.
Yeah, the kidneys are ignorant. That's why they're kidney.
You're
They're not.
kidding
They're
me.
not adult knees. I don't
Oh
know.
my god, you're kidding me. I'm sorry.
So here is when it gets more complicated, and thankfully, that's probably more the doctors. Let's do that. Probably not you. It'd be probably more about your education. So following a low salt diet is what's going to be um, effective here, just to manage the hypernatremia. And there's really not much else you can do. I have a picture to go along with it. I think this picture is pretty cute, so I like having it. Alongside everything we just talked about before we go into cushions, I do have a chart that directly compares both of them, so that should help. Well, you guys just and then I'll show you guys what about top of the on top of this. Here's a is my little chart comparison, compare and contrast table.
Yeah.
I like the wrench on the kidney. It's fun. I like the kidney. I think I have a lot in common with the nephrologist. I like kidneys and I don't care about respiratory.
Oh,
So-
bro, we're gonna beat it out. The heart. We finna beat
Oh
it
yeah,
out.
Kaylin's more of a is on the cardiologist side.
We're gonna beat it out, bro. It's so over.
They are little beans. Hopefully this helps as well. I'll give you guys that first again. Any questions on DI or SI-ADH? I like the roll. It's fun. Oh, that is yeah, that is what I don't really I think I hopefully I left feedback on that. I did remember saying I think for the specifically this lecture, it went back and forth too much. I think it would be better to just focus on one and then go to the other and then compare them after, instead of kind of comparing them as you're going along, because then you don't know what comes with kind of confusing. All right. So next up we have Cushing's disease slash syndrome. The general definition, too much cortisol. And we know cortisol comes from the adrenal glands. Oh, Jessica has a question. For the water test, the sign that the desmopressin is working is decreased urine output? Yes. So because the water test is for someone that has diabetes insipidus. So again, based on this picture here, the kidney is just getting rid of all that water. The ADH is supposed to kind of fix up the pipes. So if the desmopressin is working, the pipes are being closed, and you're no longer wasting water. So in that case, we determine that the cause is due to a lack of ADH, and the ADH is working because we're back to no longer just pissing ourselves to death. If it's nephrogenic, that means the kidneys are not listening. You're giving them all the ADH. They're saying, I don't care. I don't like this ADH. They still pee.
Like if you added two.
Yeah, I like that. Kaylin said, when you have nephrogenic disease, the kidney. What was it again? You say you said it better.
God, I'm not okay. Hello. I was saying that there's like with the ADH, it's like not ADH. I'm gonna give you attitude.
Yeah. I get added too. Oh, that's funny. Yeah, but to be fair, if you recall here, from one of your polyuria, Rochelle says you need a vocal rest.
No such thing.
The
The
ur
rest days.
the urine output for the people that have this condition is extremely high, like ridiculously high. How big is like like the Coke bottles are 2 liters? Imagine like peeing, yeah, imagine peeing up to like 10 of them. So they'll know. I think they'll know. They'll know when it's working. Yeah, like living in the bathroom. That'd be crazy. That might be the play though, because like you're like you're taking your test. You don't have to worry if you're gonna pee yourself. You're already kind of sitting in the toilet.
I forgot who not to
Oh, apparently someone in our semester does that. That's awesome.
They did it one time.
Oh,
They weren't.
oh, only one time. Okay, I would just keep doing it.
Well, no, they weren't. They had a stomach bug.
Uh,
So just in case, just in case accident.
yeah, but you might as well just keep doing it. It's optimal, right?
I don't know what to
It's
That's-
optimal.
Start now.
Like imagine like you're taking your test and then like exams off like flags you because they could hear you pee.
Be something.
That's super funny. Yeah.
You're having way too much fun with that, dude.
Yeah, it's funny. Where are we? Oh yeah, we were here.
Blech.
So Cushing's disease. So this is an abundance of cortisol. So remember, the cortisol is one of your main fight or flight hormones made by the adrenal glands. The adrenal glands work with your hypothalamus. The hypothalamus is do it coming up again. The hypothalamus is so many different functions that you don't need to know for this, but it does do an absolute crazy amount of stuff. Um, so here the hypothalamus instructs the pituitary gland. So we're seeing the hypothalamus pituitary gland working together again to release this hormone that again, I don't think you need to know too hard into detail in, but it releases this hormone that tells your adrenal glands to release some of its other hormones. And the end all be all is that your Cushing's disease is when you have too much cortisol, and the cortisol is made by the adrenal glands. That is your fight or flight hormone. Here I have the overview of the different hormones. So your adrenal glands make cortisol, aldosterone, that we should be pretty familiar with at this point. Yeah, the moon phase is one of the um potential signs of it. So your cortisol again, that's your stress, fight or flight. It does a few other things as well. So that might help you guys think about some of the assessment findings for it. So your cortisol isn't just for fight or flight. It also helps to cause gluconeogenesis, so causes the release of sugars because if you're in a fight or flight, you're gonna need that sugar release so you can get sprint into action. So I try to think of it like there's a tiger in front of you. What's more important for you to have the sugar in your body help you act or for you to fight immunity. So at that time, in the flight or flight moment, having an immune system's not gonna help you, which is why if this is constantly being high, you're having issues with your immune system. Another function is the redistribution of fat. So if we recall from your management, people that have the 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 Cushing's disease, they have a lot of visceral fat, so central fat, while meanwhile their arms and legs don't have much. So it kind of prioritizes the important organs. You have buffalo humps, all that other stuff. Oh, cool. Cortisol eats at the collagen, so that's why thin skin. Yeah, they're at risk of skin breakdown too.
They're a unit.
So the cortisol is also going to be maintaining your blood pressure, cardiovascular function. When you're having that fight or flight, your heart starts beating faster, your blood pressure rises, you're very alert, you're very irritable, alert, way to run away from that tiger. And then here is just some of the other hormones. And I listed them here just because they kind of explain some of the other signs and symptoms. So when your body has such a high cortisol level, it starts to, that extra cortisol starts to um, function on some of the receptors for the other hormones. So it starts affecting the aldosterone receptor. And we know that aldosterone leads to the retention of sodium and the wasting of potassium. So that's a way to remember the idea. I guess I don't know why I'm going down as if I wrote it. You guys are going to fill that out, but that's why you can have those issues with the electrolytes with the Cushing's condition. It also will start to pick up spots in the androgen receptors, so the male sex hormones, which is where we know the people that take testosterone, they have like the testosterone rage or the whatever, the roid rage. So actually one of your signs and symptoms of yeah, is pretty much mood swings, and that comes from the cholesterol, not cholesterol, the cortisol being so much in excess, it starts to affect the androgen receptors, and they start having some of some similar effects to like that release of aldosterone and similar effects to the release of the male sex hormone. Any questions on that? A lot of this again is just a little bit more of context and background. So if this doesn't help you remember the signs and symptoms, you can just not worry about it. But some people, I know you guys like your pathophysiology because it helps you remember. But otherwise, you don't have to. If you're the kind of person that just needs to know the facts, then this extra information here for you guys to have. All right, so there's an question. So here it's broken down into two different syndrome versus disease. Don't worry about it. It's not really something that would get tested on. The difference between it is syndrome is like a referring to like a more temporary thing. So you can have Cushing's. Yeah, it's kind of like yeah, like Caitlin. I don't know if you heard her, Caitlin. Kind of like acute versus chronic. So syndrome is like a temporary acute Cushing's due to for example, long use of steroids. So we know corticosteroids, one of the things that they can cause is decreased immunity and increased blood sugar. So if we go back up here, you see that, oh, look, your cortisol is literally just that. It can increase your blood sugar levels. It can reduce your immune function, um, or it has like an impact on your immune function. So kind of makes sense that if you're constantly needing steroids, so people that have asthma, COPD, rheumatoid arthritis, general inflammation, they're getting high doses for long term. They start having um, similar signs and symptoms as someone that has um, like a congenital born with issue with their whole little pituitary hypothalamus adrenal gland little pathway. Okay, that's just kind of that. Now we can talk about the labs. What are some labs that stick out to you guys in your head when it comes to Cushing's disease? Yeah, you guys are on it on this one, huh? Give me specific labs. Yeah, cool beans. So we'll kind of talk hyperglycemia. I like what I wrote. I wrote. I guess I'll just copy paste. Keep letting it flow. Keep letting it flow, and then I'll just kind of copy paste my own stuff, and then we can talk about it. Because I like the on mine. I put like I put extra information to explain it to me because I needed the explanation to help me remember. Kaylin said it confused her, so maybe I guess you guys will let me know.
And about that life.
And Kaylin's more about the straight facts, care about the reason later. And so we so here's what I have here. So I have increased blood sugar, and I kind of explained here the way we talked about cortisol release is fight or flight, the gluconeogenesis, like I mentioned up above. So in Cushing's, this increased blood sugar is long term and exaggerated because it's happening for a long period of time. It is going to lead to chronically high blood sugar.
Yeah.
Then decreased lymphocytes here, you can think of it like decreased immunity. And again, the reason is, again, if you're in fight or flight with your cortisol, then infection, your body's like, what's gonna kill me first, this tiger or getting an infection in like 2 or 3 days? So in the short term, this is essentially managing your body is managing its resources. It's saying put focus on what matters at hand. But if this hormone's continually elevated in the body, it's going to lead to these exaggerated long-term effects, if that makes sense. So the end all be all is immunity. Increased blood sugar, decreased immunity. They be on folic acid. Top of my head. I don't even know. Top of my head. Yeah, I don't think you need to know that. Not something that comes to me at the top of my head, so I'm just gonna go with no. Or at least not for you to know it, if it is one way or the other. Another thing I have is decreased calcium. This one's really extra information on this on the my explanation. I kind of again, you don't need to know it. You don't need to know the reasonings. It just helps me to think about it. If it confuses you, don't worry about it because this probably will confuse you. One's kind of like super extra, but decreased calcium, so you're gonna have potential bone pain, pathological fractures, increased sodium, and decreased calcium. Not calcium, but decreased sure potassium. So we talked about how when you have this cortisol level that's really high, it starts to impact some of the other um hormone receptors that your adrenal glands deal with. So testosterone here ends up leading to similar
My life.
it's okay. Serious lab changes. So the increased sodium, decreased potassium, just like how we would expect on aldosterone. And then here is the ACTH. This is the blah, blah, adrenocorticotropic hormone. So this is the thing that essentially activates the release of these hormones. And this is a feedback loop similar to your TSH. So similar to like hyperthyroidism, where in hyperthyroidism, you have so much thyroid hormone, your body stops making TSH to trigger it. Same kind of idea. Your ACTH is the signal to release these hormones. So if you have a lot of it, well, let's decrease the signal because clearly you don't need it. That makes sense? Let me know if anything here that's written in the labs don't make sense to everyone. I can imagine this one will probably confuse people. Yeah, exactly. This one will probably confuse people, so I'm just gonna delete it. No. It's extra info, so don't worry about knowing. I'll just kind of mark it as extra info. Do not need to know. Don't worry about knowing that. It's just I got into the rabbit hole because I'm like, why does cortisol make this happen?
Remember you diving into it. Dude, it's not that deep.
Kaylin said Kaylin said she remembers me diving deep into it. She's like, it's not that deep, bro. It's really not, but for me, it does help me remember. That's why I do it. But in general, you just really need to know the labs. Whatever helps. Yeah, whatever helps is whatever helps. So at the very least, I think mentioning the aldosterone relationship is going to help you guys remember because we know this from earlier semesters about like how aldosterone works, so that way we understand how ACE inhibitors work. Yeah, the hypocalcemia explains the phenomenon. Yes, exactly. So that's why that happens. So the reasons why people with Cushing have all of that is because of the hypocalcemia that occurs chronically. Again, when you're in fight or flight, all of this stuff is occurring, but definitely not to such a degree that it's causing long-term effects. But because someone with Cushing's has consistent and chronic release of the hormone, they're having this exaggerated and chronic progressive impact. Okay. So then in terms of assessment, I know you guys mentioned to me the buffalo humps. There's someone mentioned the moon face, so that's definitely that's kind of like a facial edema.
Oh, look, that was chunky. I had that. I question if it was because of that. I really thought I had Cushing for a little bit of time.
Really?
Just because of like my face is so round and I had the hump.
Yep.
Crazy stuff.
Wow.
No, I was just fat.
Bro. Crazy.
That was the reason I had it. I was just fat and in denial.
Truncal, yeah, truncal slash like visceral. So again, that's central fat. Fat in the center, but in the extremities. And again, I mentioned that's because of the cortisol. The cortisol says store fat where your vital organs are, care less about your extremities.
Oh,
And then that happening over long chronic periods of time is going to lead to that.
you know what I just thought of?
What do you think about it?
Visceral fat, like where they gain right in the middle. It's kind of like the kitties. You know how they have the little fupa as they're running around? It goes swish, swish, swish.
No.
They have like a little pouch. I think it's called like a primordial sac or something. Same idea. Extra extra cushion around the vital organs so that if they were get like bitten or impaled or whatever, that there's more protection, more distance between that injury and their organ.
Hmm.
Same idea. Look at the little kitties.
I don't know much about cats, I guess.
I'll show them the primordial. You gotta find
Primordial pouch?
yeah, or primordial sac cat.
Okay, hope I don't see any weird stuff on
I hope
Google.
not. I lost my phone. Oh, there it is.
Cushions has more cushion. I like that.
Cushion for the cushion.
Was it primordial? Cat?
Cat.
All right. Hope no weird stuff puff up.
I think that one. Yeah, hang from cat belly. Yeah, when they have the little swishy belly. Yeah, to see that little bit. Yeah, that little extra bit. It's like flappy. Like it just like exists.
Yeah.
It's not taught to their body. So when they run, if they have a big one, it just goes like this. I love them. My cat, she was so fat that she had one and it would swish.
Interesting.
Primordial pouch.
Oh yeah, we talked about the androgen release, so mood swings. Look at that.
Oh,
We said thinning hair. I'm not sure if that is like visceral fat, but if it helps her, then I'm sure it'll help you guys or something.
what?
Huh? Michelle says she thinks it's not fat. I think it's like just extra
It's
skin.
more skin, but it's still the concept is the same.
Yeah.
I think of it like the kitties.
The
Think of it
kitties.
like the kitties.
Kitties.
Yes, I do. They're my friends.
They're your friends? Yeah. Yeah, what other things can you guys think about that could test on a person with Cushing disease or syndrome? I can think of, oh yeah, we mentioned the job. I'm thinking, yeah, that's definitely some stuff there, some muscle weakness. So if you recall, one of your big things with cortisol is the fight or flight. So the hyper, well, gonna make your blood pressure go up, gonna make your heart rate go up. Another thing is that your body is like the slow wound healing. I don't think I even looked this one up for that one. It was just kind of
Using one of them all, like,
no, I didn't look. I was like, yeah, sure, why not? Let me see. Cortisol. I mean, I wasn't gonna do for everything.
it's not.
Let me see.
I am my little boo thing.
I guess it just has to. I think it has to do with a combination of the hyperglycemia, chronic hyperglycemia. So we know that people with diabetes have slower wound healing. It's because they have poor circulation. So a combination of that and a combination of a weakened immune system, also means a weaker inflammatory response, which also means a harder time getting blood flow to wounded areas. Okay, so I know there's a lot of stuff go around here. Food swings, decreased infection risk, easy bruising. Oh, we kind of already said that. And I do like having the picture of the person. Kind of go along with it. Ooh, I messed that up. That messed it up.
I'm so fucked. Take me off, get traffic duty. No. Nah.
Oh my god, nothing. I fixed it.
It is my issue.
So this little dude
Fighting.
kind of shows you kind of like a nice picture that has all the stuff that's gonna occur. But maybe on the test you'll like you remember looking at this person and then being like, oh yeah, they have all this stuff.
Oh.
Again, next up is your management. So some of the key I'll try to get you guys out of here because I know you guys are probably tired. But I'll just try to go through it quickly, huh? So your big management with this one is gonna be due to the fact that they have reduced immunity, so reduced infection risk. I guess I'll write down the big topics and then you guys can tell me what is ways to do so. So reduce injury. That goes with yeah. So remember that like we talked about, they have the FBO, the edema and all that stuff because their cortisol level starts affecting their aldosterone receptors, and we know aldosterone leads to fluid retention. So what are ways that we can reduce infection risk? Brother's son was just born.
What?
Oh, I guess I forgot. uh, his wife was in her water broke. No, it's like 41 weeks.
Really?
Yeah.
I don't know why. I remember like you were looking at a thing that said like 22.
Oh, I don't know.
Oh, okay.
Oh, here's a picture of him.
A little wrinkly one. He's cute. That's a lot of hair.
Oh, I didn't even think about that. He was just born with a full set of
How
hair.
much heartburn did this poor girl have?
I don't think she had any issues,
Heartburn?
like any complications at all. Like,
It's not a complication.
oh, I meant like nothing. I don't know actually. It's not complicated, but I heard that it was like a really chill pregnancy.
Just chilling. No such thing.
Oh yeah. So I'll go back to the world here. Avoid crowds. Yep, aseptic hand hygiene, of course. Dyslexia, man. Oh, I spelled hygiene right. One of the first times I don't put the I before the E. Or one of the first times I put the I before the E. Yeah, so avoid crowds is big. Avoid those, aka kind of avoid crowds, avoid those with infections. Make sure that they know education on reporting symptoms. Yeah, like yeah, standard precautions as well as vaccinations. Just make sure that they're vaccinated. That's gonna help them from getting pneumonia or getting the flu and having worse times. Okay, what about reducing injury? And some of this stuff kind of has to do with um, fatigue, weakness, fractures. Talked about skin integrity as well. So maybe like putting pillows under edematous tissue. Yeah, turn the patient like that one. Generally, activity could be good. So we talked about how they have risk of osteoporosis. And maybe something, I guess maybe people don't, it's like kind of somewhat counterintuitive, but if they're at risk of osteoporosis, being on the bones is actually good for building bone strength. The bones in that sense kind of function like muscles, where it's like if you don't use them, you lose them. But if you are using them, then they kind of become stronger. So before they actually develop osteoporosis, activity can help to increase bone strength.
That's a lot.
Sand integrity, trying to keep to activity, PT can help like that. PTOT. Okay, so then for skin integrity, the pillows. Thank you. Two, assess for PI, pressure injuries. And then for the FBO, what do we do for the FBO? Yeah, so we're gonna do just that fluid, sodium restrictions. We're gonna do I's and O's, current output, daily weights, all the good stuff. That's electrolytes. We're gonna use diuretics. Assess electrolytes because we're probably using diuretics. Um, hypokalemics, diuretics, and again, we've been talking about all this stuff, so I know you guys know it. So assess lungs because FBO. So do they have Um, lungs, pulmonary edema, heart failure, whatever. All right. Any questions on this one? So big things are about the infection risk, fluid volume overload, as well as general like injury, so skin breakdown. They also have worse wound healing, all of that stuff. And I guess another one, if you want to include, would also probably be um the blood sugar, making sure that that's within normal limits, best as you can, right? And something I guess I didn't include here, we'll just kind of have to talk about, is that if they're having this issue, and it's Cushing's disease, so the congenital one, the one that is happening due to a defect, as opposed to like long-term, high-term steroid usage, then a possible thing that can be done is the removal of their adrenal glands. The patient will then be on steroid replacement therapy for life. Um, and the main key thing is assessing for adrenal crisis. So I've seen this question come up. And I think I've had like adrenal crisis come up on Kaplan exams. It came up on my CAT test actually, like signs and symptoms of adrenal crisis. So at the very least, I think knowing the symptoms for an adrenal crisis is very important for it seems to be tested often. So adrenal crisis refers to the opposite of Cushing syndrome. Essentially, this is for decreased cortisol levels. So then you have to kind of take some of these labs and kind of turn them around. So instead of like increased blood sugar and increase hypertension, it'll be more like hypotension, as well as a few other potential things. The main thing here to really think about, yes, adrenal insufficiency is the same thing, same idea, same concept. So your signs and symptoms of that, the main two are probably going to be hypotension. So this could be shock, can lead to shock, that can lead to death, as well as hypoglycemia. The brain needs its sugar. And there's a few other things that it can come with, like nausea, vomiting, diarrhea. But it's gonna be really focusing on the hypotension, the hypoglycemia. And let me see what other general generic signs and symptoms. But so and I guess another important one here would be, so we talked about how Cushing's has hypokalemia. So instead you're gonna have hyperkalemia. That is also very bad. It's actually even worse than hypokalemia. So hyperkalemia, we can have lethal arrhythmias happen. Okay. And I'm trying to see if there's something I have in my brain. Ah, okay. I think this one's important too. We're gonna go with fever, and the rationale for that is that if you recall, your cortisol, your steroids are used to decrease inflammation. So if you don't have them in your body, they're too low, then your body kind of just has like a widespread inflammation, and that can lead to fever. Widespread in cortisol normally controls inflammation. Does that make sense? So fever. So if you had like a select all that apply, possible answers would be like hypotension, hypoglycemia, a fever, hyperkalemia, nausea, vomiting, diarrhea. And this is an emergency. Oh yeah, huh? A lot of H's, huh? H's and then fever. I don't know. Like I guess hyperthyrexia. That's the word for fever. Right? Or pyrexia, sorry, not pyrexia. Hyperpyrexia. Hyperpyrexia. So now we found a way. Hyperthermia too. Hyperthermia just means, I guess, hyperpyrexia specifically refers to high fever, I guess. Right? What's the difference between hyperpyrexia and hyperthermia? Let's see.
What's the question?
Between hyperthermia and hyperpyrexia.
One of them is elevation of the set temperature, and the other is overheating. I believe hyperpyrexia because your pyretics, antipyretics, like Tylenol, they help to decrease the set point. That hyperthermia is referring more to someone who's above their set point, like heat stroke. Pyrexia makes me think fire. I love that.
And here, like technically, it would be hyperpyrexia and adrenal crisis because this is the deficiency leads to a change in the normal body temperature.
Change in the set
And,
point.
a change in the set point. So technically, it's hyperpyrexia in this one, but it's the same concept. Body temperature high. That's all you really got to think about it. The semantics. You can put the yeah, like putting the semantics aside.
Well, if you give antipyretics to someone with heat stroke, it won't help them.
Oh, fair enough.
So in some situations, that does matter.
Yeah. If you heard Kaylin, she was saying the semantics of that can come up because like she was saying like someone with heat stroke has a high temperature, but not due to their core temperature. So an antipyretic like Tylenol is not actually going to do anything to the heat stroke. It's not going to decrease the body temp. That's I guess that's a good distinction to me. So in this scenario, if they have hyperpyrexic, then something like Tylenol would actually help. Yeah, pyrexia would be like yeah, yeah. Basically, yeah, above your pay grade. I don't. You're definitely not the person that would make this decision or worry about this.
I didn't order the milk for my mom.
Oh, you didn't order the milk for your mom?
I told you to let me forget.
You never said that.
Oh my god. It kills me.
Oh, yeah, but yeah, that's kind of like the main thing here. Just know it's an emergency. That's pretty much everything. Any questions on anything here? We'll do OA and RA tomorrow. And I'll give you guys the table as well. Cool beans. What's the rationale for nausea, vomiting, diarrhea? So the rationale is that there is a decrease in digestive enzymes. So the cortisol being absent or low has an effect on some liver enzymes, some effect on stomach enzymes. Uh, don't worry about it, basically. Yeah, so let me stop the sharing, stop the recording, and then we will get you guys the PowerPoint.